what would it be like actually not to have osteoporosis in the first place? You don't need to go and beg and stand and sit and lie down. Anything that we would do for somebody that we value, we should be doing for ourselves. You have to be this custodian forever. You've taken your whole life to get to where you are. It's like, wow. Produce the next generation, and then when we're done, the system isn't so interested. There'd be marches up and down Downing Street. It's entirely wanton. Men do really badly, in fact. We are anti-breastfeeding. Children would say, no, please, mom, you keep your bones. There will not be any osteoporosis. Thank you very much, doctors. It will 100% get resolved. And you get to be you. You get to be the custodian of you. It's like...
Welcome to the Visionary podcast, where we discuss science, medicine, physical health, and mental well-being. Dr. Taher Mahmud, you're the co-founder and director of London Osteoporosis Clinic, which is dedicated to screening, identifying, and treating osteoporosis. Let me begin by asking, why are you so passionate about bones? Traditionally, they are not as sentimental as the heart or the brain.
Yes, no, that's very true. I think a lot of stuff that we do, sometimes it's coincidence or by chance. When I became a consultant in my hospital, NHS hospital, my predecessor had an interest in osteoporosis. So I had come across osteoporosis as a specialty in my training and other times, but I didn't know that much about it. And so really part of it is I have to thank my predecessor because they had an interest, and I then became a lead for the osteoporosis for the NHS service. So I think that was a trigger. But as I've become more, I've spent like 2 decades plus in this area, more familiar. It really is very, I think, suited to me in that it's something that we can diagnose in a very sort of straightforward way that can be done safely. And then we have a bunch of different interventions, a lot of them holistic, using non-pharmacological approaches and very effective pharmacological interventions, which help us to reverse osteoporosis. I've got a bit of a simple wiring. I rather... in any situation that we find ourselves in or patients is to get them to a place of safety. And to get them to a place of safety, you really need to understand all their dangers and issues, and then to try and systematically reduce and minimize them and get them to a state where they're more capable. They've eliminated their health dangers, and now they have greater resilience and greater sort of capability. So we use the episode of the illness to gain a whole bunch of insights and actions and so on. So it's slightly by chance, but I've been doing this forever, and it's something I feel very strongly about. And the main wish is really not just to, yes, we can thankfully identify people relatively readily. Yes, we can even do stuff to reverse osteoporosis, which is incredible, just using the biology that we're all blessed with. But what would it be like actually not to have osteoporosis in the first place? So really my sort of evolution in this subject has really progressed towards that end. So if we really want to serve people, we want to minimize the risk of dangers and complications in the first place. So yes, we can do a bunch of things to help, but I think really to serve the humanity, our communities, is to have a greater curiosity about ourselves, learn issues around, what impacts our health in different ways, and then find small steps, actionable steps that help us improve our overall health, our sort of sense of awe about ourselves, and really be a good custodian of our sort of being on the planet, as it were. So yeah, it's sort of, and it's readily, there's a bunch of things that we can do to progress that agenda. And I've been sort of toiling with this for like more than a decade. But luckily we have some interest, we got some support, we got some guidance and leadership from a bunch of people who are taking this project forward. So we've set up a charity called Global Osteoporosis Foundation. And the idea of that is that we want to, in a systematic way, working with different partners, governments, organizations, regions, to raise awareness about this subject in different ways, sort of education, quizzes, different stuff. So that's a process that we're on. We hope to achieve this by 2040, and we will disband the charity by 2040. And I think with the guidance and input from people like you and your audience, we may be able to achieve that sooner.
In the mission statement video on your clinic, you mentioned that you established a clinic with the aspiration of eradicating osteoporosis by 2040. This is incredibly ambitious, I have to say, but we know that no valuable achievement has ever been accomplished without some level of ambition. I'm curious to know, has eliminating osteoporosis already been accomplished in other countries?
No. So osteoporosis is something that, as you say, it's a bit of a Cinderella subject. There is minimal or little interest in it. And although the subject is sort of, there's possibly growing interest, there's obviously interest from the menopause sort of perspective in bone health and so on. So this is the osteoporosis is really very underserved specialty. It causes 8.9 million fractures per year worldwide. In the UK, it's about 500,000 fractures. The health spend globally is about 100 billion. In the UK, it's about 4 billion. The consequences are not just the health spend, but a whole stack of other things. So people get complications, they go into a nursing home, they have a whole stack of other needs that become a consequence as a result of the fracture. And the impact is really beyond sort of full appreciation unless you've had that yourself or somebody in your family. And the impact is not only in the individual, but on the whole array of other people in society. So your mobility is lost. Just a quick figure, in the UK alone, every month there are just over 1,100 people die from a hip fracture. Now, the hip fracture doesn't happen overnight. We can forecast somebody's hip fracture almost from any age. You can have a child, you can have an adult, you can have an older adult, and we can do some simple assessments and say, you're here on this risk profile, the likelihood of you having a future fracture is this much or that much. And we can then put strategies into place to help people minimize those risks and reduce their likelihood of fracture and not have all those complications and consequences. So in our view, it's osteoporotic fractures are substantially or completely avoidable. They are entirely wanton. We should not have osteoporosis fractures. There's no mystery about them. There's no, it just happened. No. It has progressed over a period of decades to get to that point. So the point that you say about eradicating osteoporosis, so there are different levels of education, different levels of screening, if you like, but what we do have is experience of eradicating other conditions. So one of my mentors, somebody who took a great interest in me, and I'm really appreciative and grateful to, was Professor Sir James Black. He invented 2 drugs that rearranged the whole of medicine. He invented cimetidine, which is an antacid which stops ulcers. When I was a medical student and a junior doctor, people would regularly come in and have a bleeding ulcer, and we take them to theatre, and most of them did okay, but not all of them. We don't have bleeding ulcers now because we have effective treatments. We had other conditions in the past that caused certain amount of disability, infections, other things. He also invented beta blockers like propranolol. So people might take beta blockers for blood pressure, for anxiety, for angina, for a bunch of other things. So he invented 2 separate classes. He got a Nobel Prize for that. Anyhow, the reason why I sort of bring up his example is that he was so eminent and serious and incredibly established. And yet when I was a medical student, I had various ideas about, doing this, doing that in terms of solving a clinical problems that I was learning about. And he would meet me and share his sandwich or, I'll go and see him. Whereas the other consultants in the hospital, I said, well, I've got this idea. They won't even give me the time of day. And yet he's this, this sort of knighted professor with Nobel Prize who would just to a medical student, like a junior medical student. So we're all the product of our experiences and the people we see and the conversations that we have. And so this idea that, I've been sort of taking forward with the help of a bunch of different people is really a product of all of those influences. So I'm just like a messenger. The message is beyond me and influenced by a whole bunch of different things. So you can definitely identify clinical risk for a given medical condition, and then do simple steps intervention. You can track their progress, and so you can absolutely have an impact on many different things. Many different conditions are different now than they were when I was a medical student, when I was a junior doctor, when I was first a consultant. And this too, in time, will become something of the past, because the basic metrics that we need, a basic sort of understanding that we need to solve a problem, we know. So we know what the issues are, we know what the risk factors are, we know that if we intervene in this way or that way to minimize those risk factors. The big missing piece is that we need greater leadership from the people who are involved here. So the problem really is me, because I need to have a greater level of impact and contribution, and the communications piece. So as soon as we solve the communications piece, the storytelling piece, the sort of really, engaging with people and get them to sort of internalize it, it'll just happen. And we've got a bunch of different sort of collaboration that we're looking at that help us move to the next stage, to the next stage, to the next stage. And so it will 100% get resolved. 100%. Whether it gets resolved, in this period of time or that period of time is, I can't say. But we're on a journey and we will absolutely arrive there. And we're building together the right sort of collaborations and so on. And then in that collaboration, you guys are an important part, because, you can't develop anything without a community. And, you have that community, you have that leadership, you have that sort of wish to share and disseminate ideas that really impact and serve humanity. So yeah, we're on that journey, and it will happen.
You work with a network of colleagues and organizations to eliminate the disease. What is the mindset that you would like to see changed to reach that level of elimination?
Really key thing, how we think about stuff. And I think, I have personal experience of that. My understanding and thinking about my own capabilities have evolved over time. I've sort of had this thing, I've got this thing, this is how it works. I'll just give it to somebody and they'll do it for me. And the answer is no, they won't. It has to be me and the people that I've assembled. So the mindset is really quite simple and yet very profound. We get to be ourselves, and we somewhat or majorly take ourselves for granted. This is not, in our view, not acceptable. We get to be blessed and gifted with a whole bunch of capabilities. I can talk to you, I can hear what you're saying, it gets processed, I can see the odd thing, I can ask a question, I can, make sense of something. And yet we think, that just happened. No, that just happened because a whole myriad of different things. Now, we do have a greater and greater understanding of the laws of physics, the physiology, the biology that we are, the different sort of transactions that are taking place at a biochemical level. So we have greater understanding. So I think as soon as we get this sense of awe about ourselves, everything changes. Everything changes. So, and the awe is for all of us, people in the communication, in the media, any age. And so I think once we all get this sense of responsibility and opportunity and, do simple things, and we can't do anything for anyone without focusing on ourselves. So I think there's no point saving the next planet or another solar system. We just have to start here, do one tiny little thing, get in with the right sort of cohorts of people to sort of share and ask questions and be curious. So I think as long as the main thing would be just be a little bit curious about you and just think the awesome things that you do. How did that happen? How did you see something? What was the taste? How can you move or think or do or hear, or how did that happen? It's like, so I think if we can get people curious about that, and then get a little bit of a window into how awesome they are, stuff gets done.
Let's try to understand osteoporosis. What exactly is osteoporosis?
Yeah, so osteoporosis is really porous bone. And so bone is normally of a certain consistency and it has certain characteristics and so on. It's one of the most incredible substances that we have. And we might think of our bones as being fixed and something that doesn't change much, but they're in a constant state of change. So they're being broken and new bones being formed. That process goes at certain rates at different times. So in childhood and early adulthood, the bone is increasing up to about 30 or so. And then it remains steady for a period of time. And around later age, 50-ish, or around the menopause for women, it precipitously goes down by about 5% per year for about 4 years or so. Then it goes another steady state, but it is reducing by about 1% per year. So our bones are in a state of change. Within the bones is the bone marrow, produces all the different elements within the blood and so on. The bone has obviously the framework, the lattice upon which the muscles and the whole of our sort of system is sort of based on. So the bones do incredible functions. They have a lot of strength. They have a lot of resilience and malleability. So bones are able to change shape and do a whole bunch of different things. And so our bones are changing over time. They reach a peak and they then can go down because of any number of different medical conditions. They may not reach their full peak just because they've you had an injury, you haven't been doing stuff, you haven't been eating the right things, and then they can recover. But we can sort of track our bone change over time. And osteoporosis really is when there is a less than expected amount of bone. So we have a certain level, and there's ways of defining bone. It could be a clinical questionnaire, which is what we a questionnaire which we share with people on the screening tool that we have on the website, Global Osteoporosis Foundation, via the sticksandstones.org. If you've got lots of risk factors, or somebody's had a fracture, you had a fracture, you lost height, those suggest that you may have clinical features that suggest that you have weaker bone. So what osteoporosis does is less bone, porous bone, is that you're more liable to fracture. So you can have a certain level of trauma or insult before you fracture. And if you got osteoporosis, then a smaller insult or trauma will lead to a fracture.
Like less density or mass of the bone
Exactly.
itself.
The bone will be less. And there are ways of quantifying that. So something called a DEXA scan, we can touch upon that, helps us quantify how much bone there is in a given site. And it's a window into how strong the bones are and then how susceptible you might be to a future fracture. So if the bone density is low, then the likelihood of a future fracture is higher, and it's always changing. So we can do things to make it get a bit stronger, or it gets a little bit weaker. So osteoporosis is a clinical diagnosis. So somebody's had a fracture and they fell from a standing or a sitting position. That is by definition osteoporosis. You don't need any magical testing or visiting 10 clinics. That by definition is osteoporosis. We do the details of what's going on underneath it. There's some questionnaires that you can use, which we have. That gives you a bit of a window into, are you high risk of osteoporosis? Are you medium risk of osteoporosis or low risk of osteoporosis?
This is based on the DEXA scan or the age?
This is just a questionnaire. So those sort of things I touched on. So you had a fracture. Somebody in your family's had a fracture. You've got a medical condition. You are taking this medicine. You have this diet or this other sort of lifestyle. Increase your risk of osteoporosis. So there's just a screening tool, and that's a simple thing. And in fact, we just put out a press release this week saying, spend 5 minutes to, impact your, or save your life or something, because for a few moments you can do the question. It takes 2 minutes. You can read around some of the content that we have, and it's put you in a different place. Now you have some literacy, you have got some awareness. So, if you can't read, you can read. Now the whole world is different to you because you can read stuff. So here we're kind of inviting people to do a bit of curiosity, exploring what we have. So the questionnaire will give you a bit of an insight what your risk is. It's not a clinical diagnosis. To make a definitive diagnosis or the severity of the osteoporosis, we can do a DEXA scan. And the DEXA scan is basically low radiation, a low X-ray, mainly is that, but there are other ways, other modalities we can use to get an idea of what the bone strength is. And that gives us a number, how strong your bones are. and it's defined as being minus 2.5. We can share some graphics with you. Minus 2.5, worse than minus 2.5 is osteoporosis. And if it's between minus 1 and minus less than 2.5, then it's osteopenia. So you can say it's in the green, that's normal, plus minus 1. Between that and minus 2.5 in the yellow is osteopenia. So that's in between stage of osteoporosis and and normal. So osteopenia. And then if it's minus...
Osteopenia is in the middle.
In the middle,
and
osteopenia.
If I have osteopenia, there is more likely that I will get osteoporosis maybe.
Well, it's because you're in that in-between. So you can get better and then you can be closer to normal, or you can get worse. I mean, the main thing maybe for your viewers and listeners to take away is that your bones are super dynamic. It's not, oh, my bones sort of, I've had this and that's all good. So just as your nails are changing, your hair is changing, other stuff that you notice is changing, your bones are changing at a very fast rate. So anything you do, anything you eat, anything you do in terms of your activities, anything else that's going on in your sort of system will have an impact on your bones.
So even in mid-age, I can improve the bone density.
100%. It's your bones are all. Yes, does your nail stop growing? Yeah. It may grow at a slightly different rate depending on this or that or whatever, but it is always growing. It's always in a state of change. It's always a state of renewal and repair. And so your bones. We have patients of any age, and they get better over time, and that's our sort of minimum expectation.
Okay. You mentioned DEXA scans. How often should I have a DEXA scan if I had a fracture already, and how often if I hadn't had any fractures yet?
Yeah, so the DEXA scan has very little radiation, just so that people know what it is. The radiation of a DEXA scan depends a little bit on the machine and some detail, but it could be like 1/50th of the X-ray radiation of a chest X-ray.
So it's not dangerous in any way.
It's like being 10 minutes in a car or a plane. It's a background radiation. So Tunbridge Wells is, a little bit rocky and so on. So there's a bit more background radiation. So it's your basically background radiation. Now, there are some people, athletes and stuff, who DEXA can also be used for looking at your muscle mass, your fat, your bone, so on. And they do their DEXAs every month. So the DEXA is, so if somebody says, oh, the radiation is so much, no, this is background radiation. We still don't want to do them excessively. So normally, if you have a diagnosis and you're starting on treatment plan, then we do DEXA every year until we reach a sort of a safe level. And then we might do them, depending on the clinical picture or what the risk factors are, you may do them every 2 years, every 5 years, or very occasionally. So if somebody's got osteopenia, depending on what the risk factors are and how they're changing, you may do a DEXA, in a year or a couple of years or whatever. It depends sort of what the sort of clinical need is. But if you need a DEXA, have a DEXA, because the radiation is not, and we need a number. If I say, what's the temperature? Well, until you take the temperature, you don't know what the temperature is. If I say, what's the value of this or that, or this is why we do labs all the time. Because, we don't look at labs or a newspaper. You don't look at a newspaper that was done a few weeks or months or years ago. You say, well, what's the news today?
It has to be updated.
Has to be, at regular, because your system is so dynamic. Everything you're doing has an impact on everything. So what is it now? Well, we don't know until we measure. We can speculate and we can project from the previous readings and so on. But data helps us to be really informed. And, the other idea is that, there's only one of us. We get to be and, do all sorts of incredible things. We need to be a real good custodian and guardian of ourselves, and to, get all the information so we can then, be informed. And, we would get number for any number of other things, but we need numbers for ourselves.
Can I approach my GP and ask for a DEXA scan just because I've reached a certain age without having any fractures?
Yes. So the basic sort of, in terms of a DEXA scan, anybody can have it. We have teenagers who might need a DEXA. We have older people, adults, young adults, older adults. Depends on the clinical picture. So if somebody's had a fracture, somebody's got a medical condition, somebody's taking some drugs that might have an impact, somebody has some strong family history, there's some other reasons why we're investigating. They have a thyroid problem, they have a gut problem, they have asthma, they have some other reason, they have epilepsy, then they are more likely to have a risk, have our risk factor, and they may have an issue with their bones. And remember, osteoporosis is a bit like blood pressure. You don't have any symptoms. So with blood pressure, you may not have any symptoms. Sometimes you may get a headache or something if it was extremely high, but majority of the cases, blood pressure, there's no symptom. First symptom you might have is that you had a heart attack or you had a stroke. So unless you do the blood pressure, you don't know. So with the osteoporosis, you have no symptoms. The only symptom you're going to get is a fracture, and that's at an end stage. So the way to diagnose osteoporosis is, as I say, if you already had a fracture, if you've done this questionnaire and that suggests that you've got an increased risk, or you've got some other things going on and we do a DEXA. So I think the DEXA, there's a lot of rationing going on in the health service and so on, and challenges in terms of access and so on. So I think what people may want to do is contact the GP, say, we have these risk factors. I think you sort of have to say, I've got this, and this, I'm perimenopausal or whatever. If you just say to them, I want to do a DEXA, for some reason, people are very reluctant. There is an issue of supply, so there aren't enough slots, and there's rationing. And one of the things that really sort of, I think we can do better is that we have this mentality that we just got to have rationing. We've got to queue everywhere. We've got to wait for everything. And somehow, I don't know, it just, I come from a place of thinking that we got to, if we identify a risk factor, we got to clean it and correct it as immediately as possible and get to a place of safety. So if there's a risk, we just need to scan. We need a number. Without a number, we don't know. So we can do the questionnaire, we can do some other assessments, but the DEXA is helpful. So to ask the GP, say, well, I like a DEXA because I'm perimenopausal, I've got this or that risk factor, that might help you. If you want to,
being perimenopausal is a good reason for having DEXA scan. Because what you're telling me is that the disease starts silently.
Because you've got no symptoms. The only time you have a symptom is when you've got a fracture. So the other thing they could do if they want to, they can go to our questionnaire and print that. Do the questionnaire. It gives you a printout.
London Osteoporosis Clinic.
London Osteoporosis Clinic and the charity as well. And then get. Or we can put you a link into a specific question. We have an app that we're just releasing that they can give them some risk, and then they can say, by the authority and the sort of experience of this entity, they suggest that, I need to speak to my doctor. So we're not saying, we can't give you a clinical opinion. We're just saying you have some risk factors that might increase your likelihood of having issues with your bones. So please get some help.
It's an indication.
So you can then get the GP to explore that and hopefully they can do the DEXA for you. If they can't, you may have to go and get it done privately, or it takes a long time where you can't get to the GP. The thing is that the thing that we try and create in the clinic is this sense of authority and agency in our patients. So when we have a sense of authority and agency, we have to experience that. We have to live that. So if we find an issue that we have a question mark and we can't get it solved by this or that step, well, we have to do the next step. Can't do it by that step, we have to do the next step. We keep taking whatever steps we need to get to a place of, information, so we can say, my numbers are good, I'm doing all these things, it's good, maybe X or Y number of years or whatever, I can revisit this, or I can revisit the questionnaire at monthly interval, whatever you want to do. But I suppose the one thing to sort of say, because of this notion that we started off with at the beginning, that everybody's awesome and they get to be themselves, and it's like, wow, you get to be on the planet. It's like, no, if you've got that level of, idea about yourself, you can't just say, I asked somebody, half-asked somebody and they didn't really answer or nothing happened. I think I'll leave it at that. No.
Yeah, keep asking.
You have to do whatever you need to. Don't lose your sense of agency and authority. I mean, you don't want to be like, I'll keep asking, nobody's talking to me. Well, you have to ask in a different way or ask somebody else. Yes. So always be this sort of sense of, presence, and you get to be you. You get to be the custodian of you. It's like, wow. Yeah. It takes a lot of, a lot of responsibility and guardianship, and And then stuff needs to happen. You need to get to a place of safety, and then you clean this up. You do the next thing. I mean, it's forever because there's so many things. So yeah, ask your GP, and if you got one or two risk factors, that's fine. And I'm sure they'll do their best to help. And if they can't, you have to get it done privately. I mean, they don't cost that much.
How much, if I'm being cheeky? And
No, well, they vary depending on where you go. So I think there are places that do £100 and places that do like almost £300.
It's very reasonable.
Yeah,
for
I mean,
something that would tell you
it will give you a bit of a window in
of your bones, whether they are weak or strong.
Yeah, and I mean, you need someone to interpret it for you and so on. And we can give you some pointers here, but I think we don't want to start treating ourselves. But on the other hand, if the wait is forever and people say no, and you become really powerless in that whole exercise, you have to say, well, look, I think I'll help myself. Yeah. I'll help myself. And, I'll find out about this, I'll do that. And, where does that leave you? That leave you more informed, you got more data, you can then build some, further steps on that. That's a good investment of your time and attention.
Do we as a nation do enough of these DEXA scans?
I think the supply is limited and we could do more. I mean, there are some numbers in terms of, how many DEXA scans or DEXA sort of access per unit of population and so on. But I think most places, most countries even, the DEXAs are limited. But your people don't have to worry about a DEXA because you can do the clinical questionnaire and that gives you an answer in 5 minutes. You can say, "Oh, yeah. I've got my sort of risk profile. Please, can you action or no?" So this is why we think that a bit of awareness of the subject and having your leadership in terms of sharing some of these ideas and getting people to start doing stuff because we want this great sense of agency and authority. We have to give you something that you can experience that. So this is what we're sharing with people. Here it is. You don't need a DEXA. You don't need to go and beg and stand and sit and lie down, wait for someone to call you back. You've got this questionnaire. You're in 3 categories, and we give you a bunch of resources to do this, do this, do that. And then if you're in medium or high, you have to insist on getting help. And if they won't give you help, you help yourself.
I had a look online at the DEXA scan and I couldn't get what all the numbers and abbreviations mean. Of course, ideally, a patient should be supported by a qualified physician, but it will be very helpful if you could please decipher some of the figures for us.
Yeah. So I'll just describe it to you. So in fact, I can discuss the case with you and then you can share this. So this is a lady came to see me because she had some back pain. And she, in fact, had a fall in theatre. She's a sister in theatres in one of the hospitals. And she has a fall and the pain isn't really resolving. So they did an X-ray. And the X-ray, which is good, remember, sometimes you can't access any health sort of services. So she had an X-ray. And what did the X-ray show? Nothing very clear because X-rays are not a very good test for bone as a getting a detailed idea of the X-ray.
They're not.
It depends on a bunch of different factors, but they can give you a bit of a clue, but they're not always very helpful in terms of looking at if there is osteoporosis and so on.
So if someone had a fracture and they did an X-ray and they were told by the doctor that you will heal at some point, a patient shouldn't settle with this and insist on a DEXA scan.
Well, I don't want to, sort of advise any conflict between any clinical interaction. I think when people are seeing you, they will do their best to give you the best advice. If you have a fracture, the fracture will always heal, full stop. It will always heal. That's how it is. If you have a cut on your skin, it will always heal. It'll either get worse or it'll get better. It will not stay like a cut. Your system is always in a state of repair. So it will always get better. How much better, how quickly, how different factors and so on. So the fracture will heal, full stop. Now, if you have had a fracture and it's a fragility fracture, so if you're sitting there and the car hits you or you're on a rugby field or whatever it is, it may be slightly different. But if you are sitting or standing and you fall down, you have a fracture with that level of force, that is by definition osteoporosis. We don't need anything complicated or wake anybody up in the middle of the night to do a DEXA scan. No. So then we do the next thing, the detail. Then we do get the DEXA because we want to know the number. Then we want to do various intervention. Then we can see the number improving. So if you have a fracture, they will deal with the immediate problem and they have to make you safe then, but it needs to be followed up. And they have systems in place that sometimes there's a fracture liaison people and others in the system. They will find you and they ask you to come for a DEXA or do other things. So but obviously being proactive, asking for this can help you.
Being aware.
Being aware. So the fracture will always heal. How it heals, it can fracture again many times. So the fracture isn't, I had a fracture and I'm done. No, fracture's there. Your risk is there. The fracture can change. You can heal. You can get fracture again. You can any number of things. I had a patient this week, and she had previous maybe a small fracture. Now she's got 75% fracture. So she's got 2 fractures. Well, one of them is 75%. So the volume is this much, and now it's a quarter of what it was. So the whole sort of spine's changed. So if you this case I was mentioning, so she works in theatre, she's got back pain, and she has an X-ray. Normally, people may sort of not have the pain persist or don't get any other help. Anyway, so once we reviewed her, we did an MRI, and she had 2 fractures. And we did a DEXA scan, and she's deeply in the red. So her bone density was very low. But the only sort of feature she had was that she had this pain and it was persisting, and because she was in the system, she can sort of access and navigate her way to getting some investigations and so on. But she, in fact, had an early menopause. And some 6 years earlier, she had fallen and fractured her wrist. So anybody who's fallen, fractured their wrist, they're on a path to getting other fractures. So there were risk factors there. And when she had that risk factor, they should have done a DEXA then.
Yes.
And then they would have found that she's, a little bit in the red maybe, or in the yellow. But, 6 years on, she's not deeply in the red. Good news is, she gets some treatment and her bones get better after a period of time. So they can improve, but we can't reverse the fracture. We can't bring the bone back. There are some things we can do to sometimes restore the vertebra, but they're quite, involved and can lead to other sort of issues and so on. So there's lots of incredible things that we can do, but the best thing would be for all of us to know our bone risk and take some simple steps to improve it without having to go and see anyone, because there's no one to see very easily, and never have to go someone and wait for this and ask them to help you and be vulnerable. No, we don't need that.
Let's have a look at the DEXA scan in detail, please.
This is a picture. So this is the lady I was talking to you about. So you can see that there's green, yellow, and red. So our bone density goes up around the early 30s, remains stable for a while, and then it sort of declines around the menopause, particularly in women. In men, it sort of goes on for a bit longer and then declines a little bit less precipitously. But it's always sort of in a state of change. It's always getting better or worse, and you end up being a little bit net better or net worse. So in this case, the DEXA scan shows the normal in the green, the yellow, which is in between, and then the red is minus 2.5 or worse. And so if you see, there's different ways of interpreting the DEXA. We don't want to get people too confused, but the simplest way is just looking at those sort of lights, if you like. The green is good, the yellow is intermediate, and red is much lower. One thing to keep in mind, there are lots of sort of detail around this, in that the yellow doesn't mean that you haven't got any risk and you're okay and you can, do whatever you like. And
there is some risk.
There is risk, and the risk is a continuum. So even when you have completely normal bone, you have risk of fracture, just because there's only so much resilience and strength the bone has. So there's small risk. And then if it's a little bit less than in the yellow, it's a bit more risk. And if it's deeper and deeper in the red, the risk is more and more. I had somebody yesterday who was -5. So normal is +-1. Okay. Osteopenia is up to -2. And this lady was -5. So just deep
and it was the first time that she's seen by doctor?
She has been seen and started on offer some treatment, which she hasn't started. But she's had this new pain. She was with her family lifting one of the grandchildren and had a pain in her back. And so when we tested, we did an MRI, and this is the vertebra which was quarter of what its previous height was. I mean, I've got patients who lean back in the chair and fracture, or taking something out of a closet and fracture. Remember, your bones, you try lifting your arm or lifting somebody else, there's quite a lot of weight there's quite a lot of force that happens, is transmitted through our system and so on. So just carrying us, just breathing, just moving, just stretching, just turning is a lot of sort of force. So if your bones are very low, then you can have a higher risk of fracture.
Let's say I'm in the yellow. Do I need medication typically?
Well, we advise, we say do lots of the non-medical things, like lots of non-drug things rather, but depends on how severe you are. We can do measures to see how much bone is being broken down. So we know where you are, so you got this much resource, this is what your loss rate is, and then we can sort of identify more detail around. And you can have your DEXA, you can repeat your DEXA over time and so on. So the short answer is usually no drugs, but sometimes if it's changing very rapidly, or there's a particular thing. So one of the things that we try and focus on is looking at the underlying causes of why somebody might have osteoporosis. So if we do that, and that might need repeating every so often, is there this or that issue that's contributing to it? Is there a dietary thing? Is there a gut thing? And so there's a bunch of different factors that we want to be mindful of. So if we can, if there's a factor that's impacting the bone, so it's best to correct the source, so that your bones, so what we're not trying to do is just do the end stage. We just want to know how somebody got to that stage. One thing to keep in mind, though, osteopenia does increase your risk, as I say, because you're a little bit weaker. So there's only so much resilience that you have for.
Would you call yellow osteopenia?
Osteopenia is yellow, yeah. So worse than -1, and better than -2.5. So that's osteopenia. So that's a bit more risk. So if you're lower and lower, the risk goes up. If you look at all the people coming into A&E who have a fracture, more of them will be osteopenic because there's more of them. As a proportion, it's a smaller amount, but just in terms of total numbers. So, it's a bell-sized curve, so bell-shaped curve. So people have, very big, strong bones and very weak bones. A lot of people are in the middle. So just as a population, there are many more millions of people with osteopenia than with osteoporosis. So in the UK, there's about 3.2 million people who have osteoporosis. There's at least that number who are osteopenic, probably a bit more. And the risk of fracture is, less, but it doesn't stop you from having a fracture. So when we're in the yellow, we shouldn't say, I'm okay, I don't have to wait till, it's a bit like the blood pressure. The higher the blood pressure, the more risk. But if it's very high, the risk is much higher.
For all the young women and men out there who listen to this conversation, are there any warning signs that might indicate that they will develop osteoporosis in old age?
Yes. So anything that might have impaired your bone development, or is impairing your bone development. So if you're a youngster and you're not eating, you're not doing exercise, you're not outdoors, you're not sort of doing things to, have good balanced nutrition, or you're smoking, or you're drinking, or you've got other medical conditions, then that means you have the potential to have this much bone, but you're never going to reach that potential. You might only go this far, or you might go that far, depending on where. So everything you do, anything that everybody does is having an impact on the whole system, everywhere, and their bones. So if you're doing things that help your whole system and your bone strength and so on, then that's going to help you. And if you're a young adult or an older adult, then again, if you've got a medical condition, it's going to impact your lifestyle. It's going to impact if you're ill for any reason or immobile. That's going to have an impact. If you're a female and you have a baby, that's going to have an impact because the baby, the baby comes with a whole bunch of muscle and bone and stuff. Well, that comes from the mom. So each pregnancy that a mum has, it leads to 5% bone loss, approximately.
5%?
5% per child. So each of our mums gave us 5% of their bone when we were born, approximately. And then you have further bone loss when you're breastfeeding, or you got some other issue, or you got a medical condition, or you're taking some drugs. So it's always in a state of change, and people can do lots of small things to help improve their whole system and their bone.
Yeah. So how early can we predict osteoporosis in someone who hasn't had any fractures yet? Can we predict it at any time?
Yeah, so we can. There are some tables and sort of graphs that we can use to forecast. So yeah, it doesn't. You don't have to have a fracture. It depends on, have you got any of those risk factors? You know, are you female? Are you older? Have you got somebody in your family with a fracture, with a hip fracture? Have they got a medical condition such as, you know, thyroid, inflammatory arthritis, rheumatoid arthritis, ankylosing spondylitis, inflammatory bowel disease, asthma? You know, there's a whole list of any of those conditions. They're smoking, they're drinking, they, you know, are prone to falling. You know, there's a whole stack of those sorts of things. And then their risk is a bit more than if they didn't have any of those risks. Now, if they reduce some of those risk factors, then the risk will get better. They will get less likely. So yeah, you can and then you can do these things at intervals, and you can supplement those sorts of questionnaires with a DEXA scan, and that can give you a bit of a number. And as I say, we don't need to necessarily do DEXA scans, you know, without a good clinical justification. But you know, the threshold for doing a DEXA scan should be relatively low.
Which means that osteoporosis is not necessarily an age-related condition, and we can get osteoporosis at any age.
100%. You can get osteoporosis at any age. And, you know, some of the graphics that, for example, the National Osteoporosis Society or the Royal Osteoporosis Society, you know, one of their graphics is they've got, you know, people of every age and gender, and you can get osteoporosis. So you can get osteoporosis at any age, but your bones haven't fully formed or fully sort of settled at the peak bone mass around the early sort of in your sort of early 30s. So it sort of goes up, and you know the increase is about sort of completed by about that sort of age. So yeah, your bones are always changing, and then looking at your number, and then looking at your number at multiple times in terms of your risk factor or your scans and so on will give you a bit of a clue. You were there, now you're there, or now you're here. So what's the change? So if you have serial stuff, you can get a bit of an idea of what the projected path that you have. Obviously, the group sort of profile we know, but as the individual, you know, we need our own data points so we can say, oh, well, I was there, now I'm here, I've done this intervention, it's made that difference, now I'm going to do that intervention, it's going to make the other difference.
In that case, I'm wondering when we should pay more attention to our bones. Young people in their 20s might not be overly concerned about that, but someone like me in midlife, I'm 46, I eat well, healthily, I exercise regularly, I haven't had any fractures yet, but I do not know the condition of my bones. Should I start initiating any action to find out how strong or how weak my bones are?
Yeah, I think I know you're very conscientious about what you eat and what you do and so on. So I think that's putting you in a good state. So nutrition is the foundation of all health, as you know, activities and so on. That will help you maintaining your strength, your muscle mass. That would help you. If there's anything else that's contributing, sort of be curious about that and correct and optimize that. It's worth checking simple bloods and so on, just your general bloods, but also vitamin D. Vitamin D is low in a lot of people. It's best, especially in the winter. So in the autumn coming up to a time when we can't make vitamin D in the sun. So from about October to April, we can't make vitamin D in the skin. The rest of the year we can. But it depends on a bunch of different factors. Not everybody's very efficient at making vitamin D from the sun. So taking supplements and then a DEXA scan. So if there's some risk profile or there's some other reasons or perimenopausal, then you're doing a DEXA scan, discussing it with the clinicians. And then once you have a number and so on, then you got some awareness. Now, if somebody's got a DEXA and they're like +1 or something, or it's completely normal and so on, and everything is good, and they're really conscientious and everything is steady, well, you don't need to run off and do another DEXA unless something else has changed over a period of time. But yeah, if it was low, if it was in the intermediate range, then it would be worth doing it, depending on the clinical features, every few years, just to see what it shows. There's lots of other things that we can do, but as long as you're maintaining your general health, your sort of activities, your sort of nutrition, that's going to be helping. And then your target, or people's target, should be that they want to be like a little bit better. We want to be in a state of growth. We want to be in a state of improvement. And so one of the big things that we try and encourage people is to be really active. And in the clinic, we have lots of resources like classes, like strength training classes and Pilates and yoga and so on. And they're sort of every week we have a class for each of those things. And the previous videos we have recorded, people can access them. They're available, freely. So there's some small bits of resource that we have. So make use of any of those sorts of things. And just, reading and understanding what's going on, checking some general things. As I say, if we do have this notion that it's incredible that we get to be ourselves, then, anything that we would do for somebody that we value, we should be doing for ourselves. So if people have children, what do you do for your child? Yes. And, you're not going to put up with the temperature and say, I'll go next week and see what the temperature's like. No, you were in A&E that evening or that night. For yourself, have a similar standard where you say, oh, that's not right. Oh, I'm not sure about that. Or maybe I'll get some advice and then, do stuff in real time.
So in terms of supplements and assuming that I have a good, half-decent diet, do I only need vitamin D?
Well, it depends. Usually vitamin D is very low. So in many studies, it's super low in majority of cases, like 90% even. So usually vitamin D is low and you can't make it in the skin. And you have to have some supplements, especially in temperate climates. In different parts of the world, it's different. But we don't have to guess about vitamin D. We need data. So we have a number, and number says it's this, or it should be, it's not where it needs to be optimally. So vitamin D is like, there may be some people who get a bit of vitamin D in different forms of diet or whatever, but it's near impossible. Unless you've got some big stores or there are other characteristics that you might maintain your vitamin D regardless of taking supplements. So I think majority of people need vitamin D. But rather than guessing or wondering or just sort of, doing, just some veterinary pharmacy, we check. People can check. It's a simple test. You can order online. It costs no, £30 or £40 or whatever. You can do it yourself. Or you can ask your GP if you're able to, and then you have some sort of value, and then you can use that to, have this much or that much vitamin D, and you can track it over time. So vitamin D is really, really valuable. And sometimes you need other supplements as well. But if you're going to start anywhere and say, what do I do? Vitamin D is a great place to start.
Okay. You touched on exercise. When I was growing up in the 80s, it was all about being skinny and aerobics, Jane Fonda style. Okay. Now you mentioned strength training, Pilates. What type of exercise that will help me bolster my bones the best?
Yeah, so I think with the exercise, the main thing we say is do stuff that you enjoy. Do stuff that's safe. Do stuff that's not going to cause you injury. Do stuff well within your capabilities. Do stuff that's, in a group if you want to, because that'll create a community that, so on. So do simple things. It doesn't have to be anything heroic. It's basic movements. But the main elements of it are that you want to maintain and gently build your strength, your muscle. Yeah. So you can, arms, core, legs, and your flexibility. So the issue isn't, as we get older, the expectation is, we do less, we get weaker, we have no muscle, and we have got no flexibility. And then when we have an injury or an issue, we're not able to correct ourselves. So if you can do, different things, you might like, aerobics, that's fine, but not all the time. You want some strength stuff, you want some other, just body weight stuff. You don't need anything, ridiculous. Simple stuff, and get some level of competency and understanding, and then you can gently build on it, and then you can gently build on the next bit, and so on. So it's all of these things are forever. because you have to be this custodian forever. And so you keep gently building and adding in sort of different layers of different things and so on. But the basic metrics are maintain your weight, maintain your muscle, maintain your strength, and gently sort of do things that you find interesting and enjoyable, but not necessarily just one or only thing. So yeah, aerobic stuff is good, but you need to mix it. Swimming may be good for flexibility and stuff, but if you need other things for strength and so on. So there's a bunch of things that people can do, but start with simple stuff. Start with things that you enjoy, and then gently incorporate other sort of elements.
So in midlife, we typically still work, we care for a family, and we don't have loads and loads of time. This is the lazy woman's question. What is the least I could do weekly to maintain half decent bones?
Great question. And it's not lazy. You just want to get the most out of your time. I think the main thing would be your strength and your stamina and your energy. So if you're doing stuff and your stamina is getting better and your energy is getting better, and you're able to do things and it's with ease, that's great. You're maintaining it, because maintain stuff is effortful. You can't just say, think it just happens. No, nothing just happens. Everything is as a consequence of different intention, and sometimes not always very conscious. So wherever you are, that's where you are. And so yeah, I think if you want to be vital and capable and like productive in your final decade or your final time on the planet, you've got to invest now. This moment, wherever you are, that's where you have to be. So I think people that take an interest in the subjects that you cover are already on that curve. They're already proactive. They're already doing stuff. But they can always be a little bit of a nuanced further thing and so on. So I think wherever people are, that's amazing. Well, look, you're doing incredible stuff. You've taken your whole life to get to where you are. It's like, wow. Now, do the next thing. And do the next thing. Get coaches, get mentors, get people, get community to keep sort of moving, having that forward momentum. It's just gentle progress, so that you're able to, build on what you already achieved.
Yeah. You mentioned muscles a few times. And how does muscle mass affect my bones? Is there a correlation between both of them?
Yeah, 100%. So if you lose muscle for any reason, you will lose bone. Yeah.
How would that happen?
Well, there's a many different sort of mechanisms, sort of physical and chemical, that the two are very tightly coupled. Okay. So you can't say, I think I'm going to lose 500 kilograms and have no muscle, and that's going to be great for my overall health. And the answer is no. So if you want to gain more bone, you have to gain some weight and you have to gain some muscle.
Does this mean that bodybuilders have strong bones?
It depends on how they build their body. But generally speaking, yes. Yes, they will have. There's an optimal for everything. If I stay up all night or sleep all night or all day, that's not optimal. So with everything, it's an optimal. And so we don't want too much muscle, but on the other hand, or we want to achieve things in the most efficient, correct, safe way. But yeah, overall, if you're a bit stronger and you got more muscle, then you will have more bone.
You just mentioned safety. Are there any types of exercise that could maybe erode my bones or maybe work as a wear and tear accelerator?
Yeah, so anything that you do which overexerts or causes an injury to your joint or soft tissue and so on. So that's why we're always making the case for being a little bit cautious, and we have a few examples, and we have apps and other things that we share with people to give them some instructions and videos and classes and so on, so they can sort of gently follow that, but at their own pace. So that we and they can have individual classes as well. So anything. So start very slowly and then gently build it up. And the main mantra with all this exercise stuff is no injury. We do not want injury, because if you have injury, it messes up your whole thinking, messes up your whole schedule. You lose a lot of weight. You lose muscle. rearranges your whole psychology. We don't want, we don't want any heroics. We want small, steady, controlled progress, and and then you know how all it's with any project, if you do small, steady stuff, you say, well, how did I get here? Well, you got here because you made small, steady steps, and it's very predictable.
Is there a certain kind of food that I could eat to increase my muscle mass?
No, any food you like. Make sure you got enough protein in your diet. But I think just a good balanced diet, a little bit Mediterranean. Avoid sugars. Avoid sort of processed stuff. Alcohol, yes, alcohol, maybe minimal, but our general advice is don't go near alcohol because there's no safe dose. There are different opinions and so on, but I think, we use alcohol to clean skin or clean the bugs on a tissue that we're going to operate on. So we don't use it to grow things, we use it to kill things. So your body's got a degree of resilience, and you can tolerate some bits of exposure to alcohol, but on the whole, it's best to avoid.
Now, let's say I was diagnosed with osteoporosis. What are the signs that I should be watching for that might indicate that I'm not healing properly or my condition is worsening?
So the conditions, well, if you're losing weight or you're becoming mobile or you've got other medical conditions and you're taking stacks of stuff to control those other medical conditions, the likelihood is all of those things are negative factors. So anything else going on with you, or you're not eating properly, or a bunch of other sort of factors, or they're giving you different interventions and you're not able to fully progress with those interventions, be that exercise, lifestyle stuff, or different supplements or medicines, or you've had another fracture. So you've got evidence that there's stuff going on, and then obviously you can measure different things. You can have a DEXA, and that'll tell you what your numbers are, and that's why we do serial DEXAs during active phase of treatment. We do DEXAs every year. Once we reach a safe place, then we can have them very occasionally or relatively rarely.
Yeah. In midlife, we have usually accumulated some conditions and diseases. So how does osteoporosis interact with other conditions? And are there any medications on the market that could actually weaken my bones?
Yeah, so many things. The biggest culprit may be steroids. Obviously, the bigger the dose of steroids, the more of an injurious effect they will have on the bones, as well as many parts of the body. Epilepsy drugs, any drugs that's used for any inflammation, which sometimes may be steroids or really related to steroids. Antidepressants, antacids. Can have these effects might be minor. So I think if you have a condition, please continue to safely be treated for that condition. But that may be a reason why you need a DEXA. That may be a reason why you need to just track things over time. That may be a reason to do some other things that might help you. So I think the short answer is that many or almost anything can affect your bones. So if in doubt, just do some exploring. And can we do something to minimize or reduce the risk factors?
So you encourage patients to Google things and find out themselves, then approach their doctors.
I don't know about Googling things. I think get reliable information. There are lots of good sources of information. There are different societies. We have some stuff on sticksandstone.org. And there are many other societies. I think Googling per se maybe not always helpful, because there are lots of, you're in the space where people have a lot of opinions, and the way to get attraction for your opinions, you have to be controversial, and that's not necessarily serving the reader or the listener. It's serving the person making the point. So I think you have to be really quite precious with your time and attention, and be careful, how you use it. So So I think definitely research reliable information. There are many good sources. But make use of your healthcare people. They're there. I know there's some challenges in terms of access, but they're there and they want to be helpful and they want to serve your needs. So I'm sure they'll assist. And obviously we've got bits of resource that we're more than happy to share with you.
People don't usually like to talk about race when it comes to health conditions and maybe sports. But are there any racial risk factors that might have an impact on my bones?
Yeah, I mean, I think rather than race, we can just talk about size. Yeah. If you're very slight and whatever race you are, you're going to have less of everything. You're going to have less weight, you're going to have less muscle, you're going to have less bone.
So I shouldn't aim to be skinny.
We spend most of our time encouraging the people that we work with to get stronger and to get heavier.
I'm also trying to figure out if I'm doomed by my ancestors. How much do my genes influence my bones?
Yeah, so we are a product of everything. So there is an influence, and it can increase your risk, particularly if your mum or one of your parents had a hip fracture. That doubles your risk of having a fracture, if you like, approximately. There are other factors, but yeah. So the genes have an influence, but it's a small part. Lots of other things have a much bigger influence.
You mentioned on your clinic's website that bone health starts with childhood. When I heard you saying that, I got alert all of a sudden. You had my attention because I have an 8-year-old child and her bones are something that I don't usually worry about.
That's a good
just
question.
Because she's so young. What can I do for my child, or what can I give her to make sure that she will not struggle with bone weakness in old age?
Yeah, that's a great question. And the main thing is really that we touched on earlier. I think if you make sure she's safe, she's active, she's doing stuff, she's physically doing stuff, and her nutrition is balanced, I think, and she's growing and she's getting stronger, and she's putting on weight, and her growth spurts are normal and so on. Those are really valuable things. So if she's not eating, her growth isn't sort of to be expected, or some other things are not happening. So with older children and teenagers, so if they're maybe their diet isn't fantastic, or their weight is a bit less, and they may have started periods, but then the periods are not very frequent, or no periods, that's an indication that they may be osteoporotic. So the first osteoporotic cases were in fact young athletes who had no periods, had a particular diet, and were underweight. So I think the best thing that we can all do is be as sort of balanced, and maybe in quotes, normal in terms of our sort of activities and so on, rather than being extreme here or extreme there, in terms of our activities. So if they're eating okay, their weight's okay, they're exercising, they're doing different things, then yeah, I think those are good things.
I heard you talking about teenagers. Now thinking of all those female teenagers who don't have regular periods due to, as you mentioned, poor diet or maybe unmanaged stress. Does this affect a female's body?
Yeah, so obviously, if you're underweight and you're malnourished,
it will affect
your whole system is compromised. And bone is just one aspect of that. Your period is just one aspect of that. Your neurological development is going to be another aspect of that. So, everything's interconnected.
Yeah. On the clinic website, I heard you saying that 1 in 2 women above 50 and 1 in 5 men will suffer from osteoporosis fracture at some point in their lives. This sounds very, very common in women, a sort of gender inequality in physical power, I have to say. We women live our entire lives with the ebb and flow of hormones. Menstrual cycles affect us. Pregnancy takes away by default 5% with every child. Breastfeeding, also for the lack of nutrients. Then comes menopause. When I reach 50, me personally, which is in 4 years, what will happen to my bones?
Yeah, so the bones are always in a state of change, and that change is accelerated around the menopause. So people can lose approximately 5% bone per year for about 4 years, maybe 5 years.
Starting from which age?
Starting from around the perimenopause. So as the estrogen maintains the bone strength. So if the estrogen is going down, some other factors may enter. You're losing bone. And so once you're sort of established after a few years, it reaches a steady state. So it may be like this, then you have this precipitous decline, and then it goes to another sort of steady state. You're thinking of what to do to minimize that.
That would be a good idea. But I'm thinking, what will happen to the bone density itself? It loses mass.
Yeah, so your number might be in the yellow, it could go in the red.
Just because I'm menopausal.
Yeah, because your whole system is dependent on a bunch of different factors, and one of those factors that's positive is being removed, is no longer there. And some other things might happen. You may not be so active, maybe a bunch of other stuff going on, this or that, So the net effect is that your bone is changing. But, we don't have to guess, because you can have a scan. You can have this, you can have that test, you can have tests to see how much bone is being broken down. So you say, oh, look, my numbers are like this, I need to do that.
So you're telling me that by default, being a menopausal woman would make me susceptible to bone weakness. I'm wondering now, is there an evolutionary reason for that?
I mean, it's difficult to speculate. I mean, the one sort of view of evolution is that, we're here to, produce the next generation. And then when we're done, the system isn't so interested.
Collapsed.
But you say the women have, a hard time of it. I mean, they are by far the stronger, gender. They have many gifts and capabilities. I think sometimes you sort of, don't. I think the thing with mums particularly is that they invest a lot of their time in their family and their children and so on. They slightly overlook themselves, and so it's not inevitable that the bone will go like this and everything will collapse, but that's what happens. So if we know there's a danger and there's an issue and we're coming to that, we take evasive action. So we can know the numbers, we can take this step, see what the result is. Oh, okay, it's give me the result I want, do the next thing or whatever it is. So the fact that we know all of this stuff, and the fact that you guys are so capable, so, gifted, the reason why I want to get Eradicate Osteoporosis is partly because of the situation where we've got people who, it's more women obviously than men, is that they've been selfless, they've done this, they've done that, they've done the other, they've done da-da-da for any number of different people and community and so on, and now they're here and we just say, oh, off you go, you have a fracture, good luck, you're not going to survive, but, or you may be in a home, we're okay. We know the issue. It's wanton. In our opinion, it's entirely wanton. The fractures that happen, especially if somebody's already had a fracture or they got a risk factor. So if this was another happening in another group of people or another age group, there'd be marches up and down Downing Street. There'd be, people doing, whatever. But as it is, it's sort of overlooked and like, oh, you'll be lucky to get a DEXA, or we've got this thing for you, take it or leave it, or like, here's treatment and come back in 5 years. Those are not acceptable standards in our view, but, we are where we are. It's great to have something, but we just got to keep building. So we have this sense of dis-ease, discomfort, that this is not an acceptable standard. We're, on the planet looking to contribute, make a difference before we leave. We can't be hanging about and accepting this as an acceptable standard.
Yeah. What about men? Does dwindling testosterone weaken their bones as well?
Yeah, as they get older, lose bone. Men do really badly, in fact, all health conditions or most health conditions. So you might think, oh, men have it easy. They die earlier, they have more violence, they have more complications, they have less sort of networks for asking for help or receiving help or making use of help. And then as far as osteoporosis is concerned, they take forever to be diagnosed. People say, oh, you're a bloke, you haven't got osteoporosis. Or people don't really assess them, and then when people do assess them or make a diagnosis or give them something, then because we are a little bit sort of challenged, we don't always follow the instruction, so we end up having all the sort of issues of whatever it is that is there. I mean, things are changing, but yeah, it's a serious problem.
This is a big debate, really, one that extends beyond this conversation. Mm-hmm. But for optimal bone biology in a child, should a mum breastfeed or give formula milk, assuming that she has a choice?
Yeah, so I'll be open with you. We are anti-breastfeeding.
Why?
Well, this is because, yes, you need to breastfeed for the first few weeks, possibly, or for a short period of time. Beyond that, the mom's losing more bone. So I've got patients, who have osteoporosis around the pregnancy. They get multiple fractures. And if the convention is, and everybody expects them to breastfeed, and they're losing more bone because they're breastfeeding, and they've already got an injury and a fracture, and that's reducing their life expectancy. So the mum has done an incredible, generous act of having the baby, donating everything that the baby is to the baby. Now, the baby needs to, do other things to help the mum. The mum cannot be losing more bone. Every 6 months that mum is breastfeeding, there's another 5% bone gone. You can recover some of that, but not all of it. So this is the thing. So, I mean, the reason why we're a bit sort of, it's the mums and the grandmas who are liable to get these conditions, and then they're like overlooked. I mean, one of my colleagues in the charity, the trustee, John May, amazing guy, does incredible things. And one of his points is that, we want to help grandmas to survive and to thrive and to be healthy. Because as soon as you take that grandma away, the family disintegrates. Yeah. Their sort of values, their sort of social cohesion, their sort of connectedness. We need the moms and the grandmas to be, secure in their health. Because there are social implications for grandmas being everything. Not able to move. Yeah, we so this is so if the end point is, I breastfeed forever, and then I'll have multiple fractures and I'm going to die X number of years earlier, and I'm going to have so much disability. I think most children would say, no, please, mom, you keep your bones. Yeah. A great number of women take hormone replacement therapy to manage the unpleasant symptoms of menopause. Mm-hmm. How does this negatively or positively affect bone density? Yeah, so there are lots of sort of issues around HRT and so on. It's becoming more popular, and it's got some different clinical values and so on. But the summary is that the HRT helps bone. So bone is a little bit stronger because of HRT. And the reason why the bone gets less or around the menopause in a precipitous way is because of the loss of estrogen. Let's say I see you with a fracture or two, and I was diagnosed with osteoporosis. What are the traditional mainstream drugs that I could be taking to manage my skeleton? Yeah, so sort of conventionally, most people will be offered something called alendronic acid, which is a tablet. It's effective. It reduces fracture rate by about 50%. It's once a week normally. There are other versions of this, related drugs, so once a week, once a month. So like 19+% of people will be offered that drug, unless there's some counterindication or there's some reason they can't take something like that, or there's an issue, or they've tried it and it's not been, there's some side effects, and then they would go on to something else. Okay. I know that your academic research is based on the side effects of drugs. Are there maybe any severe side effects or tolerability issues associated with these drugs? Yeah, so the bisphosphonate is the most popular drug. They're sort of first line of treatment in guidelines. They can be helpful. They can improve bone strength a little bit, but more importantly, they reduce the fracture rate. However, there are tolerability issues. Maybe about half the people have stopped taking them by about 6 months because they can have stomach problems. You can't swallow them. The tablet can be quite large. They can have sort of other issues. They can have some complications with the jaw, something the dentist don't want to operate on you. So we normally say, if you are going to go on something like that, have those assessments by the dentist before, or if you're planning to do something, then get all the major dental work done. If you've been on them for a long time, we didn't know this initially, but obviously we discovered after a period of time that if you're on it for more than 5 years, particularly if you're on from 10 years, then your risk of a spontaneous fracture goes up. So you can get a hip fracture. With all of this stuff, medicine's always changing, so we're always in a state of sort of better understanding of how to use this, how to approach that. Our approach in the clinic is drugs are last thing we use.
The last thing.
Because we want to use everything. This sense of agency and authority has to be that you're doing stuff and helping yourself and so on. And the drugs and the doctor are like over there, and we want to get rid of the drug and get rid of the doctor as immediately as possible, so you can go back to being all powerful and so on.
So we touched on the side effects. Is this why you advocate for non-invasive treatments?
Well, I think we just want the most effective treatment, and the idea is to get to a place of safety as immediately as possible. So we advocate, understanding what the cause is, then addressing that cause. And, if that's the cause of the osteoporosis, then the osteoporosis should get better because, we found this, we found that, we got another reason why something's happening. So do all of that. And then we want to look at non-pharmaceutical interventions. And then, depending on how severe it is, then we can do those non-pharmaceutical steps and then see how much progress somebody's making. And if they make good progress, then we don't need to do more. So if somebody's in the yellow, they get a little bit less yellow, great. Well, we're good. If they have lots of complications or they're in the red, then we have to look at more effective treatments. And the most effective treatment are really anabolic, so where the bone is growing, and you can get a substantial increase in your bone in a very short span.
What does anabolic mean?
So anabolic means growth. So anything in a state of growth. So you can have two types of medicines broadly. One is it stops the breakdown. So the medicine is there, the bone is there. We don't want it to break down and get less and less. So that's one approach. And the other is wherever the bone is, we want it to grow. So the breakdown has a small effect in terms of the overall bone amount after a period of time, whereas the anabolic can have a more of an effect in terms of bone growth and restoring the bone.
If someone has a family history of osteoporosis and by default they are at high risk, they are now in their 40s, they have seen how their parents struggled with the condition, and now they want to prevent the disease rather than waiting and seeing what's going to happen.
Yep.
You are telling them now that it's not inevitable that they will develop osteoporosis.
100%. They just have to know what the risk factors are and address their risk factors gently, track their numbers, do different steps, mostly lifestyle. If you do need something else, you need something else. But yeah, I mean, there's only one of you. And if you have got osteoporosis and you got people in your family, and you know what the broad sort of career path for osteoporosis is, that you have this fracture, you have that fracture, you have that fracture. So anybody who's listening to you and has had a fracture, has had a wrist fracture because they had a fall, or somebody in the family had a hip fracture, their parents, they're at a higher risk than they would otherwise be. And the likelihood of them having a fracture is much higher. Therefore, they need their own assessments and their own data to know where they are, and then take steps to. So it's not, oh, you got this, you're done. No, you got this, and then there's plenty to be done to, minimize the risk, and then you can track the risk over time.
So this is the holistic treatment of osteoporosis, is to prevent it in the first place.
Yeah, exactly. Well, holistic, doing different interventions and so on all the time, and then prevention. Yeah, that has to be the best thing. It's like the sort of discussion at the minute about changing the NHS and so on. And I mean, it's not rocket science. There can never be enough resource to do healthcare and social care for everybody who is ill and needs social care. Because quarter of the population, quarter of the workforce has to go into serving those needs. So why don't we go to the source and stop it from happening in the first place? So we have some, suggestions of what we do with osteoporosis, and we can apply different things to different other areas.
And you're telling me that I can indeed maintain reasonable bone density till the rest of my life, if I do the right thing.
If you do the right thing and you measure it, so we don't have to guess. We say, we do this, we're checking, we're all good, we're not, let's do this, let's do that, do whatever we have to keep, be safeguarding that.
Yeah. So if I see you with a fracture or two in your treatment plan, not only do you take holistic measures to relieve the pain and fix the broken, but you also propose ways to prevent the progression of the disease and even reverse it.
100%.
So I have a funny question. We're now recording on the third floor of the penthouse chambers here in Tunbridge Wells. I start climbing the stairs so energetically, only to struggle on the last flight of stairs. No specific pain, just a feeling of fatigue and achy in my legs. Does this project weak bones or weak muscles, or both?
It just suggests that you're not as practiced as you might be. Okay. So if you did that stairs, gently, you did it once, then you stopped, and you did it again a few minutes, an hour or two or later, then you did it. Your body is very plastic. So you do a bit of weight or stuff, or keep looking at something, you're going to see more deeply than you did before. And after a while, you've got another level of capability. Then after a while, you've got another level of capability. So if you're a little bit sort of, there's many flights, so it's sensible. I mean, it's normal to be a little bit sort of, out of breath. But if you keep doing that multiple times gently, you're going to get stronger. If you didn't do any of those, then you would have less So we're always in a state of change. We're always in a state of change everywhere. So we're either getting a little bit better or a little bit worse. Yeah. So let's set you a challenge then. That
I need to do better.
Oh, no. You're doing amazing because you're doing stuff. So why don't you do this? When you come to the top, go down one step and then come back up again. And then
I will feel better or worse?
No, you're just stretching your system. So next time, come up and go down 2 steps and come up. And then next time, go down 3 steps and then come up.
Yeah, and
before long, you'll be doing it multiple times.
Yeah, and it would be a clear indication out of my everyday life that I need to work harder.
Gently build other things. I know you're very particular about lots of stuff that you do, so you can just sort of gently incorporate this into it. And just explore and just make it fun. It's like, what happens now? I'm going to do one more step.
Dr. Taher Mahmud, we conclude our conversations with moral or ethical questions. I appreciate that these questions can be a little bit challenging to answer, but my personal belief is that medicine is never in isolation from the big questions. What are your concerns, if any, about the handling and treatment of osteoporosis in the UK?
Yeah, I think we can do better, like substantially better. And better for me means no osteoporosis fractures.
What advice would you give junior doctors about osteoporosis?
I mean, they have a lot to contend with because they're sort of busy and they're dealing with a lot of acute stuff. So junior doctors on the whole doing acute stuff. And, somebody comes in with a heart attack or whatever, or chest infection or septicemia, bones are not a priority then. But I think if they can become a little bit curious about the subject and ask some, gentle screening questions, or see they got this risk factor, that risk factor, they're on these drugs, or they got that, or this to get immobility, and just, maybe get people a little bit curious about the subject. But with everything, I think we have to start with ourselves.
Yeah.
So the junior doctors, make sure you're eating, make sure you're doing simple things to look after you, make sure you're being kind to yourself, doing simple things for your own health, for your own bones, for the people around you, your family, your grandma. And because we're so capable, we'll get this fixed in no time, this condition. So it's not a problem. But yeah, I think they're doing great jobs and, doing incredible stuff. They have to focus on the acute stuff, but, when they have a moment to breathe and, be a little bit broader, then they can look to include this in their assessment. It takes a moment.
Do you think our doctors here in the UK might need more training or education about osteoporosis?
I think we everything is changing all the time. I mean, in a couple of weeks' time, I'm at the American College of, I'm at the American Society of Bone and Mineral Research, and so there's tons of stuff going on all the time. So we all need education. Medicine. This might be interesting to know. T-life in medicine for medical knowledge is about 70 odd days, maybe less than that. So every 70 odd days, what we thought we knew is slightly changed. And what we thought we knew slightly changed. What we thought we knew. So in terms of education, yes, we all desperately need education. And this is a subject that obviously, could do with a little bit more attention. But I think for everything, rather than saying do more, I think let's just do less, focus on ourselves, improve our own resilience, so we can then get more done with less.
Are there maybe some visionary treatments or research developments about osteoporosis that you would like to see happening or progressing in the future?
Yeah, our project. The visionary thing is there will not be any osteoporosis. Thank you very much, doctors. Thank you very much, the health service. Thank you very much, everybody who wants to treat me. I don't have the condition.
Because it is
we're getting rid of it. I know my risk. I'm taking these steps. I'm tracking my progress. I'm good. It's not going to happen to me. It's not going to happen to me.
Till the end of my years, people now live
that's
longer.
That's what we'd like, because to really serve people is to stop their problem. Get rid of their problem. You're not going to have a problem. So you don't need me to be heroic and do this, stand, lie down, ask you to do this, be dependent, waiting on this test, or what does that mean? No, you haven't got the problem. Please continue to do your stuff for the planet.
Dr. Taher Mahmud, you have kindly diagnosed my osteoarthritis and Raynaud's disease, and I'm still very grateful for the correct diagnosis. I think it's half the battle. Your discourse on osteoporosis is full of hope. It's never doom and gloom, and I think this is what patients need. The idea that they are not destined to a life of drugs. You also give people agency. When I feel empowered, I do better, I work better, I make things change. And this is a message of hope. Thank you so much for being here with us today.
You're very kind to invite me, and it's a real privilege to see you in the other sort of setting. But, it's a real privilege and blessing to be of some use to patients and the communities that we all serve and so on. So we got a bit of time on the planet. We want to get the most done. So it's amazing to, have your time and to discuss this with your team and so on.
Much appreciated. Thank you.
Thanks.